Well, because of your graciousness of coming early on back, we propose we move on with the next session. It was a bit earlier start with your permission. So thank you all for that. It's amazing to see such enthusiastic group and fantastic debate. It's hard to follow. My name is Natella Rachmanina. I'm professor of pediatrics here in Washington, D.C. at Children's Hospital and George Washington University. I'm also senior technical advisor at Elizabeth Glazier Pediatric AIDS Foundation. I've been involved many years with this workshop, and it's truly a pleasure to welcome you here in DC. I apologize for the weather this morning, but you know, in Africa, when we start many meetings, particularly in the dry season, we clap our hands asking for rain. I was doing opposite in my car, trying to get the clouds out until the policeman saw me on the Connecticut Avenue and didn't think I behaved appropriate. So, Kat, you are not the only one who got some authorities interactions coming here, so even local people. But anyhow, welcome to DC. We do hope that you find a few minutes of your time to see cherry blossom. It's absolutely stunning, beautiful. It's very close distance from here. You can just walk here. And if you do have a chance to visit Women's Museum, it's truly a fantastic experience. It's a very pleasant museum and fun to visit, and a lot of great places around to eat if several of you go together. So with that, let me welcome you to a very special session today. This session is sponsored by National Institutes of Health, and the goal of this session is to really put the spotlight on research in the area of HIV women, from prevention to comorbidities, lifespan, you name it. I have with me my co-chair, Dr. Kate Powers. She is from Massachusetts, Harvard Medical School and Massachusetts General Hospital. I have known Kate for years as one of the leaders in the national and international HIV research. She has years of having worked in Botswana. She leads a lot of research initiatives within FOX, works with many stakeholders, including NIH, and she will be talking today about the CFAR network in the beginning. And then I also am happy to welcome our first part of our session guest, Leslie Marshall. On your program, you have a different name. Dr. Leslie Marshall came to represent National Institutes of Health. She is a senior science advisor on the NIH Office of AIDS Research, overseeing a portfolio including women's health, neuro-HIV, microbicides, and non-vaccine biomedical prevention, and she is a co-lead of HIV and Women's Signature Program at NIH. This is the first round of presentations, and then we will move on 3 clusters of presentations by 2 people each, and we will be introducing people along the session as we go forward. With that, I'd like to first invite to the stage Dr. Marshall to give us some overview of NIH research priorities. Please welcome.
No? Test? Yes. Better. Okay. So first, I'd like to acknowledge Captain Glenshaw sends her regrets. She was unable to be here today for unforeseen circumstances, and provide thank you on behalf of the NIH Office of AIDS Research, or OAR as we call ourselves, to the workshop organizers and to the symposium co-chairs for giving us some time to talk today. My name is Leslie Marshall, and I'm a senior science advisor and co-lead of the NIH HIV and Women's Signature Program. And I just wanted to start with a reflection on why are we here today. We're here because HIV heavily impacts women, and primarily women of color and adolescent girls and young women worldwide. In the US, over 250,000 women and girls are estimated to be living with HIV, including up to 5,000 pregnant people. Between 6,000 to 7,000 women and girls in America were diagnosed with HIV in 2021, and a third of those were over the age of 45. We're all aware that there's excessive, disproportionate impact on Black and brown populations. Globally, the picture is a bit starker. In 2022, UNAIDS estimates that there are an estimated 39 million people with HIV worldwide, and more than half of them, or greater than 20 million, are women and girls, including over 1 million pregnant people. In sub-Saharan Africa, adolescent girls and young women accounted for a staggering 77% of new infections among young people aged 15 to 24 years. And adolescent girls and young women are greater than 3 times as likely as their male counterparts to acquire HIV. Despite all of this, women and women's health considerations remain underrepresented across the research continuum. But we're gaining momentum. The intersection of women's health and HIV is a priority for the National Institutes of Health, and the Office of AIDS Research has a long-standing commitment to research for women with HIV and impacted by HIV. We accomplish this in partnership with our institute, center, and office partners across the NIH. And last year, at this workshop actually, OAR formalized this commitment to establishing an HIV and women's signature program, which we accomplish in collaboration with the NIH Office of Research on Women's Health. So we formalized a long-standing partnership. And I think it was very important that we did it at this workshop. Part of this signature program is to support efforts like the International Workshop of HIV and Women by establishing opportunities for young, early-stage investigators and emerging leaders in the field, and provide opportunities for them to present their research, like we did last year in the symposium, and the workshop organizers are continuing this year. Today's symposium highlights important work of the CFARs for women's health, and we're really happy to see the inter-CFAR collaboration on HIV research in women, which is co-led by today's session co-chair, Dr. Kate Powis. A lot of co in there, but I think that's because women like to work together, right? So I just want to leave you with, I think that the time is now, more than ever before, for us to capitalize on the momentum that we're seeing. The importance of women's health research is being realized across the federal government. This year, the First Lady's office announced the Women's Health Research Initiative, and we just saw a corresponding executive order coming from the White House. This includes 20 new actions and commitments by federal agencies, including $200 million for research at the National Institutes of Health. Furthermore, the HHS, Office of Infectious Disease, or OIDP, and HIV/AIDS policy launched a nationally coordinated, community-driven initiative named For Us, By Us, focusing on addressing the unique needs of Black women in the HIV response in the US. So like I said, the time is now. Before I hand it back over to Dr. Powis, I just want to bring to your attention and highlight some slides you may see at the break and some more information you may see in the program book. In March, we published in the March issue of Lancet HIV a position paper summarizing the symposium from last year's workshop and detailing activities ongoing and planned for the future in the NIH HIV and Women's Signature Program. As you may know, we had a RFI that closed earlier or late in 2023, and we're working on summarizing those results and we'll be publishing them soon. And finally, the annual OAR virtual workshop on early career investigators in HIV is going to be happening April 24th, 2024 from 11 to 4. There'll be more information on those slides. You can use the QR code, and we encourage all early career investigators to register and join in. It's a really unique opportunity to learn more about the NIH, and thank you for listening to me today, and I'm going to hand it over back to Dr. Powis.
Great. Thank you very much, and we're so excited to have this opportunity that is sponsored by NIH and the Office of AIDS Research to talk about or to provide talks on women's health. But before we do that, if you could bring slides up potentially. I want to tell you a little bit about the inter-CFAR collaboration for HIV research in women and the Center for AIDS Research. So you may or may not be aware that there are 19 centers for AIDS research throughout the United States associated with academic institutions. And the working group has been in existence actually since 2009. Our mission is to actually have a network of both CFAR investigators and community members dedicated to promoting cutting-edge research to extend the knowledge and foster action to address gaps towards understanding the complex biological, clinical, socio-behavioral aspects of HIV in cis and transgender women. And the group's addressing relevant issues relevant to HIV in women, both domestically and internationally. Working group activities and structures are really designed to promote and mentor development of early stage investigators and underrepresented investigators. And our group is really interested in networking among investigators and community members with similar research interests, developing collaborative grant proposals, harmonizing data and research endeavors between cohorts to answer scientific questions with rarer outcomes, offering mentoring and reviewing grant proposals under development, providing external review of CFAR developmental awards related to women and HIV, and in-person networking at a biannual symposium. So we actually organize 4 meetings a year. Every other year we do the symposium. Our symposium was in San Francisco this past year, and our next one will be in 2025. And you can see that over a course of 2 days, we covered reproductive health, antiretroviral therapy and metabolism, aging across the gender spectrum, and NIH, HIV and women's research priorities. We hold a webinar in March, June, and September. Our webinar that just passed, we had an opportunity to hear about HPV elimination and also about INSTI switch during menopause, possibly related to hypertension. And then in June, we will get an update on U.S. guidelines and relative to women's health, and we'll be talking more about cardiovascular health. We would love for you to join us. We have over 500 members in the working group already, and across the top is the web page for the group. If you have really good eyesight, then you can see which of our programs. Our program is listed midway down the level, and if you click on that, it will get you to the Become the Member section. I do co-chair this with Maria Alcaide out of University of Miami, and please reach out to any of us, either of us, if you're interested in hearing more about the group. But with that, we've got an exciting format for this session. We're going to hear from 2 speakers at a time, one individual giving a talk, followed by someone commenting on that talk. And our first set of speakers is going to be Julie Chesnader. Fairly good? Okay. Julie is an assistant professor and early stage investigator at the University of Alabama, the School of Nursing. She is a certified advanced practice nurse with over 12 years of experience working with people with HIV in various clinical and administrative and research capacity. And she really has had a growing interest in women's cardiometabolic health, where she's contributed to gender tailoring of cardiovascular prevention program for women veterans. She's going to be talking to us today about avoiding weight bias in healthcare for women living with HIV, and that will be followed up with comments from Dr. Amanda Willig, who is an associate professor at University of Alabama and has a secondary appointment at UAB in the Department of Nutrition and Sciences. She is also on the executive committee of the research coordinating committee for the Center of AIDS Research at UAB in integrated clinical systems. And She has had a focus on nutrition and physical activity solutions to promote healthy aging in adults living with HIV. So with that, I'll turn it over to the two of you.
Thank you, and thank you for the Conference Planning Committee for the opportunity to be here. This is my first time at the conference, so it's kind of a big deal to be up here speaking to you. So, in full transparency, Dr. Wheeling suggested that I discuss this topic, and my first thought is why. It wasn't a topic that I had spent a great deal of time thinking about in my work, but it was a valuable thought exercise, so I hope you enjoy coming along for a ride with me kind of through that process. So, because I didn't know a lot about this, the first thing I did was I went to the literature and I said, okay, what do we know about this topic? And it turns out that we don't know a lot about it within HIV specifically, but there are some things that we can learn from the greater literature. So first, when I talk about what body weight bias, what I'm referencing are negative beliefs and attitudes towards individuals that are living with overweight or obesity. And those beliefs usually center on causality and controllability of weight. So what do you believe causes weight gain or obesity? And how much control do you think an individual has over their weight and their ability to control their weight? So I mentioned there's not a lot of research in this space. I was able to find 2 and now 3 published studies on the topic in HIV specifically. And what we can glean from this work is that women with HIV report frequent weight stigma, but there's reasons to believe that there may be differences in experiences of weight-related stigma based on HIV status and gender. And so in the bottom right, I have a quote that hopefully you can read that gives you some perspective of what this might look like. That quote was taken from one of these 2 studies that I'm referencing. And the table at the top summarizes findings from a second descriptive study at a single site in New England, where they observed that individuals that aren't living with HIV actually reported a greater frequency of weight-related stigmatizing experiences. But when you broke that down by gender, women with HIV did in fact report a greater frequency of these weight-related stigmatizing experiences as compared to women without. In general, we know that weight bias tends to be directed more towards women as compared to men. So I would argue that this problem of weight bias is going to be increasingly important in the work that we do. And some of that is just based on the fact that there's growing attention to obesity and HIV. So there are a number of drivers for this, and I've mentioned a few here. There's increasing numbers of individuals that are already living with overweight or obesity at the point of their HIV diagnosis. We talked about earlier today that there are differences in weight gain that have been observed based on use of certain antiretroviral drugs. A great example are the integrase inhibitors. And based off of the data that we have right now, there's limited evidence that simply changing somebody's regimen is going to reverse that weight gain that they might experience. We've gained a great deal of knowledge about adiposity, adipose tissue, both its distribution and its function in the body. Specifically understanding that individuals with HIV have differences in the distribution of the fat in their body, and they may have dysfunctions in those fat cells that contribute to increases in their cardiometabolic disease risk. And then, of course, we've all heard about these new weight loss drugs that are available on the market and the potential benefit that they might have in this and other populations. So we also have some guidance for screening and treatment of overweight and obesity, and much of this comes from guidelines for the general population, but we do have some practical guidance within the HIV literature specifically. And I would call attention to kind of a key point in this one publication that yes, we do need further research to better understand the pathophysiology and optimal treatment of these conditions within HIV, but there are significant risks associated particularly with obesity and adiposity, central adiposity and fat distributions in organs such as the liver, the heart, that are concerning, and we really do need to consider intervening now. When we do intervene, we need to be mindful of the potential impact of weight bias, because there's substantial evidence that weight bias is pervasive in healthcare. Work hasn't been done in HIV, but when you look at what's available, we do know that negative weight bias has been documented extensively, both among medical students, and what you see to the right there is a figure that was extracted from this particular publication showing over time some of these explicit biases of students, and a non-trivial percentage thought that laziness and ignorance were significant causes of obesity. In addition, we have studies that demonstrate that pick your professional discipline, there has likely been evidence of either implicit biases or just automatic preferences for thinness, or of explicit biases among a range of different healthcare providers, including those that are engaged in research and treatment of obesity. So we need to assume that we are not immune, even though we are quite aware and sensitive to the impact of HIV stigma, and try and address this routinely in our care. So I'd like to point out, too, that there are negative outcomes that are associated with healthcare-directed weight bias. And the point of this is to show you that we might be working against our goals and the health goals of our patients if we are engaging in conversations in such a way that are going to be stigmatizing related to their weight. So I was asked to think about how this affects my work as an early career investigator and a clinician. And I think it's important to point out that I'm an HIV primary care provider. And increasingly, my work is, I still manage HIV and prescribe antiretroviral drugs. But increasingly, the bread and butter of my work is managing these non-HIV chronic conditions, which are of concern both to me and to my patients. Hypertension, dyslipidemia, diabetes. It's increasingly hard to avoid having conversations about weight in this context. On the flip side, I'm also a clinician investigator, and my work centers on health services interventions to support cardiometabolic health in people with HIV. And I'm routinely trying to engage with my patients to have them help me develop and evaluate interventions that can be delivered in an HIV primary care setting. Separately, I've kind of taken on some interest in looking at psychosocial and behavior factors that also influence cardiometabolic health in women. So I point this out to you to say that, I hadn't really thought about weight bias, and it should be central in the work that I do. So there has been some work that points out some challenges that were really directed at care and management of obesity and overweight, but I think they have some relevance to research as well. So one of the things is this over-reliance on weight and body mass index as a marker of health. And we know they're imperfect measures. In fact, this concept of adiposity and these fat distributions may be more important. But as a provider, it's really easy to go to the chart and pull up a weight and a BMI and compare that to the last medical visit to dictate whether or not I'm going to talk about weight or BMI in the course of that encounter. The next challenge is when an individual tells me that they're interested in weight loss, how can I communicate what realistic expectations are in terms of not only the amount of weight they're likely to be able to lose, but how that might relate to the health outcomes of interest? How much budge are they really going to get in their blood pressure with a 5% weight loss? How likely are they to be able to sustain that weight loss? Another challenge is thinking about how we keep a social determinants lens when we're thinking about lifestyle support needs for our patients. I often have 15 to 30 minutes to address the health issues of concern. How much information am I able to glean about the environmental factors that are contributing to their lifestyle and their health behaviors? Another challenge to think about is we kind of broadly say, oh, you have a BMI over 30, perhaps you should be losing some weight. But how keen am I to recognizing any addictive behaviors or disordered eating patterns that might actually be a contraindication to me recommending self-directed weight loss? Is weight loss always safe for my patient population. And then, of course, those wonderful new drugs that are on the market. How do I overcome those financial and insurance barriers to help individuals get access to these weight loss medications? So I don't have answers to all of these problems. I'm just trying to raise awareness to this as a particular problem that we're going to continue to face in our work. But I would encourage you that we can make the most of our available resources while we continue to get evidence on the factors driving these weight-related risks for our patients and the best treatment approaches in individuals that are living with HIV. And so first at the top is a reference that Dr. Wheeling had recommended to me, which points out approaches to treat obesity, to say, hey, it's okay to talk about this as a health problem, but we can do it in a respectful manner while recognizing that weight bias exists and having more effective conversations and developing more effective treatment plans with our patients. And then recognizing that list of challenges, that's not all for me to manage. I'm really fortunate to be at the 1917 clinic where I have an array of specialists in different disciplines at my disposal that I can pull in and say, help me with this. And I recognize that not everybody has that opportunity, but I would encourage us to think about who we could recruit to the team that may be able to fill in some of those holes. Dietitians in the VA, we were fortunate to have access to health psychologists in our primary care centers. We can use board-certified obesity treatment specialists, but also think about how we might train and bring in ASO workers or community health workers to help with some of this. And then finally, patients, right? Like, this is the bread and butter of what I do, is participatory approaches, right? Engaging people in development of these interventions. So again, I don't have solutions, but I'm here to just point this out as an issue and generate some conversation about how we might start to think about this as we're moving forward in treatment of overweight and obesity in our patient population. Thank you.
Julie, that was great. And maybe Mandy, if you could come up and just comment on that presentation, and then we'll take a few minutes of questions. So if you have questions, be ready.
Okay, thank you. About something they didn't want to hear that day. So we have to think through those topics accurately. And the final thing that I will leave you with on this topic that Julie has mentioned is the fact that all of the research you saw there and the overwhelming body of research with a broader community that deals with weight stigma and how people themselves actually want to be approached and actually want you to address topics like this or don't want you to address topics in certain situations are exclusively focused on cis women and do not in any way take into account the larger issues of how sexual and gender identity may influence someone's feelings about this and what the best approach should be. So there are clearly lots of avenues for future research and clinical care discussions and interventions to look into. So I really hope that some of you will come away from this thinking about how you can implement some of the things that Dr. Schick-Nader discussed today.
Thank you. So excellent talk, and we already have some questions. So microphone 2.
Hi, Anna Puga, Vive Healthcare and Care Research, Florida. I have a comment and a question. We did a focus group before hiring a dietitian for our clinic and found out that stigma, it goes both ways, right? Our patients in this one region felt that if they lost weight, they'd be accused of being a crack addict or being sick and dying of AIDS. And so weight was a protective thing for them. And if we don't see all the areas of stigma, I think it's really hard to address. But how do we deal with healthy lifestyle and healthy eating when they can't afford the food that would help, or the exercise places, or it's unsafe to jog or walk in their neighborhoods?
Yep, so I will say, just a quick plug, on Monday with University of Florida Care System, we're doing a whole talk about this. Because one of the realities is that many of our patients are going to be experiencing issues of low income, food insecurity, food access. And I will put the disclaimer out that our clinic is very fortunate in that we are participants in the 340B drug pricing program here in the United States. And HRSA has given us permission to utilize those fundings to operate food assistance programming. That has been transformational in the lives of many of our patients. But I think the first thing is just bringing it to the awareness of the providers. You need to have some idea of what the baseline status is for where your patients are and what they actually have access to. You can actually provide support and advice and guidance right where someone is that day on how to effectively eat to just be generally healthier than you were the day before, a little bit more physically active than you were the day before, and that will still have an impact. And it's one of those things where I know we've had many providers recently in clinic who have been really trying to tell patients you need to avoid as many ultra-processed food products as you possibly can, and you need to completely stay away from anything that's not fresh food or this kind of thing. The reality is you can work with any situation, but you need to know what the situation is. We also deal with this issue in our clinic where many patients are very hesitant to lose weight because they're afraid of the stigma that people might think they're losing weight because they have HIV or because they're using active substances. And one of the things that we try to work with our providers on is facing the reality that if you can discuss healthy eating and physical activity in general, which again, Alabama, it's 100 degrees during the summer. You're not going to be exercising in the middle of the day. That's the time you have, right? So talking about those practical, realistic strategies with someone and the fact that just shifting body composition in general from being healthy without any actual impact on the body weight itself is going to improve your blood sugar and your blood pressure, and it's going to improve the symptoms that you're experiencing during the perimenopausal transition. So there are a lot of motivations to try to help someone slightly shift themselves from where they were the day before on how they're eating some things without these big transformative changes that we think we have to force patients to.
That's great. And I think we have another question. No. Any other questions before? Yep, microphone up front. And we'll take one more question, so thank you.
Thank you so much. That was really wonderful presentation and response. Did you, in your work that you're doing, find any evidence of women, migrant women that have left sort of Southern Africa and come here? Did you address any cultural norms about diet and exercise I'll give you an example. Growing up, we sort of had suds and meat and vegetables probably 6 times a week and ran everywhere and swam everywhere and were very active. Then moving to the global north, those ingredients are not available, so now I have to adapt to eating things that I didn't grow up eating, and I don't know the nutritional value of them unless I actually ask someone, and then that conversation becomes really, really difficult. Have you come across this? And if so, how have you addressed it? And also, in some of our cultures, a woman wearing sort of jogging pants and things like that in public is frowned upon, or things like that. So have you considered or come across some of these cultural difficulties?
So we'll say in our local, so I'll talk about two different things. First, our local clinic population, the majority of our women who have immigrated from other areas have tended to come from South America and the Caribbean. And there is very much sort of an ethos for many of these individuals that having a higher body weight is a good thing. And that is something that, to be perfectly frank, we don't discourage. If we start to see that blood sugar levels, high blood pressure levels, those things are becoming an issue, then we start to engage a little bit more about healthier behaviors. And when I talk about healthier behaviors, again, we're lucky in our clinic, as Julie said, to have dietitians who are already there. So they can sit down and say, okay, what do you eat at home? And teach me, educate me about the kind of foods that you're actually going to be willing to go out and purchase and buy. And that has changed a lot of the thought process around how we approach patients, because all of our dietitians are born and trained in the United States at our clinic. So that's something where we've really had to make the effort to step out of our boundaries and say, teach me about your foods, teach me about what you are willing to eat, and I guarantee your natural cultural diet is a healthy one, and we can find a way to make that work for you. One of the other situations that we've had to work with is on the research side of things. We have a research project, Adolescent Girls Empowerment Program in Zambia, based out of Lusaka, Zambia, but working in the Copperbelt region and some of those areas. And you're right, one of the biggest challenges has been that the predominant diet is within Shima, so a heavy corn ground meal, called ugali in some places, and then meat relishes with very small vegetable relishes. So having the community health workers who are very involved in that program go out and talk about very small ways that you can affordably increase the vegetable relishes and why you might want to do that for the girls, giving them actual reasons of why you can do this and fit it within your budget, and it's something that it's okay to do, it's culturally appropriate for you, has been more successful than just coming in and saying, okay, just make this change, make this blanket change. So it's something that we've tried to incorporate. At the same time, it's something that we fall abysmally behind on constantly, and we're always, I think, playing catch up as opposed to leading the way. And we need to get to a position where we're proactively doing these things.
Great, thank you. We appreciate the questions that are coming in from our virtual attendees. We've run out of little time, so we are going to move on to the next two speakers, but keep the questions coming in and we'll try and address them. And with that, Serena, I'm going to ask you to head up to the microphone while I do the introductions, if I can. Serena Reddy is the technical head at WIT's Reproductive Health Institute in Johannesburg, South Africa, and she is currently pursuing her PhD as a research scientist. She really has substantial experience in observational studies, qualitative studies, and clinical trials, working with adolescent girls, women, and young women as well in the space of prevention. And we're going to hear a little bit about PrEP today in the global setting, and that will be followed up with comments from Christina Saros, who I have the pleasure of working with at Massachusetts General Hospital. She is an associate professor at Harvard Medical School and also does a lot of qualitative research in her portfolio. She both works on implementation science and qualitative work around prevention of HIV and in the PrEP space as well. So take it away, Serena.
Thank you so much. So today my talk is on PrEP-related biases and barriers among adolescent girls and young women in South Africa. I have to say that this is my first time attending the International Workshop on HIV and Women, and so I'm very excited to be here. and I'm also very nervous. This is my first presentation at a symposium like this, so it's a disclaimer for me. And also, I think the jet lag is starting to sink in because in South Africa it is almost nighttime. But I will do my best. So I'll start off talking about HIV in South Africa, since it's important to know the prevalence in which we work and that in which our AGYW are living. In South Africa, we have the largest burden of HIV. It is home to about 20% of people living with HIV globally, and the prevalence among adults greater than 15 years is about 16.3%, which equates to about 7.4 million people living with HIV. The prevalence is twice as high among females compared to males, and it is unequal across regions and populations, which you can see. Not sure how this works, but you can see in the first image there where you see the 9 provinces of South Africa and the varying shades of green depicting the increases in HIV prevalence. And so HIV particularly affects women and young people, and pronounced differences by sex have been observed. And you can see in the second image here that HIV prevalence amongst 15 to 19-year-old and 20 to 24-year-old women are about twice as high when compared to the male counterparts. And then for those aged 25 to 29, it's about 3 times higher. These data are from the 6th South African National HIV Prevalence Incidence and Behavioral Survey, which were recently published. And then when it comes to incidence, I was unable to get more recent data on incidence, but I do have data from the ECHO study. ECHO enrolled 5,768 women aged 18 to 35 in South Africa. And recruitment was not based particularly on drivers of HIV risk, such as transactional sex and STIs and high-risk behaviors. It was pretty much based on site location, whether participants were sexually active, and if they were seeking contraception. However, as you can see in the table there, the rates of new infections were higher among adolescent girls and young women when compared to those older than 31. And in this particular study, having new or multiple partners and baseline infection with STIs was strongly associated with HIV incidence. I'll then just quickly go on to show you some of the incidences of STIs among AGYW. This is from a recent study published in 2023, which shows that STI infection rates amongst AGYW in South Africa, age 15 to 24, is around 30%. And infection is twice as likely among women than men, which is similar to the HIV epidemic. With regards to HIV PrEP rollout, South Africa has been very active. We are one of the earliest adopters of oral PrEP, with PrEP being registered in 2015, and more recently the dapivirine vaginal ring and the cabotegravir injectable registered in 2022. Rollout initially started in 2016 at select facilities targeting sex workers, and then expanded to include men who have sex with men, university students, adolescent girls and young women, and other populations at substantial risks, and finally, more recently, pregnant and breastfeeding women. In terms of the cumulative initiations, our total PrEP initiations is about 1,300,000, and that includes oral PrEP as well as a dapivirine vaginal ring. Injectable PrEP is yet to be rolled out. And then this is, although not the most recent data, it was the latest I could find, but you can see that in terms of the trajectories of countries with most PrEP initiations in sub-Saharan Africa, South Africa is doing really well and showing our progress as well as the commitment to increasing PrEP access, with about 900,000 initiations as at 2023. However, despite the high access or the accessibility of PrEP, data that I could find from 2022 shows that only 8.8% of sexually active people were taking PrEP, and that's an increase from 0.1% in 2018. And only 4% of sexually active AGYW were taking PrEP, which is up from 0.1% in 2018. And while these increases are important and a good step in the right direction, uptake along with adherence and persistence need to be much higher to make a significant impact on the current HIV infection rates. So we'll move now to the patterns of oral PrEP use among AGYW. So So the research that we've done so far and the information from the PrEP demo projects have shown that South African AGYW are willing to take PrEP with an initial prescription and a bottle of pills. There is early use. However, the behaviors necessary for sustained use in HIV protection, which is your persistence and adherence, are frequently cited challenges, which sometimes leads to discontinuation. Additional research has also shown, however, that AGYW do re-engage with PrEP use, and sometimes with improved or more consistent use. And therefore, there's a lot of literature which indicates that PrEP use among AGYW is a journey that includes uptake, early use, and persistence, and also lots of pauses and restarts and discontinuation as their needs for PrEP use changes over time. But there's limited data on how AGYW needs for PrEP change over time and how they recognize when to stop and restart PrEP. And therefore, it's critical to understand the barriers and biases related to their PrEP non-use so that we can assist them in their efforts to restart PrEP and ultimately reduce HIV incidence. So now I'll move into the actual barriers and biases. As we all know, adolescent girls and young women do not exist alone. We all exist in a setting that involves family, networks, and society, and thus the PrEP-related barriers and biases can be imposed on a socio-ecological framework which takes into consideration the effects of the individual, the relationship, community, and environment. So South Africa is beautiful. I'm from there. It's a wonderful place, and lots of tourists adore it. It's home to approximately 61 million people, and however, this is not the reality that many face. Majority of the population is living in poor conditions with poverty, unemployment rife, shared living spaces, poor sanitation and housing, limited access to water, food insecurity, and rising costs. Electricity disruptions and load shedding I cannot stress. It impacts the poor and for lack of a better word, the poor, it impacts everyone, right? Nobody is safe from the load shedding and electricity disruptions. Crime is also rife, as is traveling between cities and countries for employment. So although South Africa is doing its best with PrEP access, it's hard to be adherent to PrEP when there's no access to running water or food or places for storage, and that's something that needs to be considered, especially for AGYW. Moving on to community, PrEP HIV stigma is a major bias, and that's with regards to taking a medication for HIV and an assumption that you could be living with HIV as well. Then there's sexual activity stigma, which is related to the taboos around early sexual debut and also sexual activity for young and single women. There's also healthcare provider biases where some staff may make clinical judgments about who is and who isn't a good candidate for PrEP, and that's based on unconscious or conscious attitudes about whether adolescent girls and young women are responsible enough to take PrEP and if they are going to be adherent. And then lastly, what came up for me was the clinic burden. The clinics in South Africa are massively overburdened. If you come into our areas or into our clinics in where I work in Hillbrow, you will see lines that come out the clinic and down the street. The waiting rooms are full. The nurses are tired. The individuals coming to the clinic are tired also and walk out because they're tired, they're hungry, there's no food, and there's lots of issues like that. And this kind of setting doesn't make it easy for good and adequate care and counseling for AGYW. Then we move on to relationships-related barriers and biases. Disapproval from family and sexual partners is one. Unsupportive partners. HIV and sexual stigma, again, this time with the judgment that if you are taking PrEP, then you must likely be promiscuous. Then also non-disclosure to partners makes it difficult to take oral PrEP daily. And then also there's the fear of accidental disclosure, which may result in embarrassment and humiliation to be seen taking a drug for HIV. And the role of partners is very significant here due to the gender inequalities that exist in South Africa, as well as a reliance on male partners for financial security. And then lastly, individual, which is the biggest one, mostly related to issues related to the study product. So side effects, pill taking burden, fatigue, the large size of the pill, the dislike of taste, remembering to take it daily, again, embarrassment to be seen taking it daily. And what also came out quite a bit from the reviews that I did was that a lot of adolescent girls and young women had a low perceived risk of acquiring HIV. And until they have the tools, this is their own assumptions. So until they have the tools to determine their actual risk accurately, it's hard to shift the dial for risk awareness and to improve PrEP use. So to this end, this is a little plug for my PhD project. At WITS RHI, we're running the PALESA study, which stands for PrEP Restart for Adolescent Girls and Young Women using STI self-testing and assessment. It's a small trial, it's pilot randomized controlled trial with 55 AGYW aged 16 to 18, non-pregnant, HIV negative with discontinued PrEP use within the last 6 months. We're following them up for 6 months with a mixture of in-person and phone visits. And we're offering them 2 study arms. It's randomization, so one study arm is doing self-testing with the VISB sexual health test at home, along with the risk assessment that we developed using the input of AGYW, and the second arm is just using the risk assessment only. The progress is ongoing, and we aim to finish our follow-up in May of this year. We do have some preliminary results that we have submitted to HIV R4P, and we're excited about. And hopefully we'll have some good data there. Somebody mentioned earlier today, and one of the earlier speakers, that it's easier to solve a problem when you're closer to the problem. And I think this is very important, especially with AGYW, that we get their input and data in terms of work like this for more successful outcomes. And so in conclusion, AGYW experienced many barriers and biases which make it difficult to sustain prevention behavior. Further, PrEP services need to be further tailored to help reduce these biases and to foster better prevention and control in the future. And we need to improve our understanding of PrEP use among AGYW so we can provide adequate guidance to empower them. So this is a picture of my team at WITS RHI. This is when we completed our enrollment into the PALESA study, which is one of the biggest cohorts of adolescent girls 16 to 18 we've ever done, so we were very proud. And then lastly, I'd just like to thank everyone for listening to me today, and the young women who teach us so much and inform our research, our site team, my supervisors, Prof. Palani Phillips and Prof. Renee Heffron, as well as all our donors and funders. Thank you very much.
Thank you, Serena. That was great, giving us the context. Christine, I'll invite you up. It's certainly a challenging context, even as you presented in the ecological framework.
Thank you, everybody. It's a pleasure to be here, and I feel very lucky to have been invited and to offer a few comments on Dr. Reddy's excellent talk. So I think I'd like to center my comments around 2 key areas. And I think the first one is this concept of risk. And Dr. Reddy, you highlighted that, it's very difficult it's difficult for young people in particular to kind of quantify their risk for HIV and to understand that. And I know there's a movement now, which I support, to think more or less about risk and more about enhancing wellness. And I think the danger with continuing to talk about risk in the context of HIV is further stigmatizing young women and healthy sexuality. Risk is also really uncomfortable for people to think about. We don't like to think about risk. It doesn't make us feel good, and we tend to shut down and kind of avoid things that make us uncomfortable in that way. The reality is that these young women live in a high prevalence area, so there's probably always some risk. And can we shift the dialogue to help young women focus on enhancing their wellness and embracing sexuality, and help healthcare providers do the same, and what impact might that have? It also reminds me of some work that I did with my partners in South Africa a number of years back, where we interviewed young women who had a pregnancy around how they think about HIV in the context in which they make decisions about their sexual well-being. And what the women shared, Dr. Reddy, your slide kind of comparing and contrasting the 2 South Africas, the tourist paradise, and then also where many of these young women find themselves. The young women really drove that point home. Many of these young women did not have strong social support. They lived in very difficult environments, and their male partner played an incredibly important role in their lives in terms of providing financial support, but also social support and love and human connection. And to think that that person might cause you harm or is exposing you to risk is probably really difficult. So again, shifting the dialogue to one of enhancing your wellness rather than thinking about risk. Relatedly, I also want to note the importance of offering sexual wellness products outside of the health setting. As we saw, health settings are overburdened, and there's also opportunity costs to going to the health center. There are many of them, but time is also a big one. Young people have other things going on in school and lots of other places to be besides standing in long queues, and then only to be greeted by someone who might feel overburdened and stressed and may stigmatize them around their sexuality. So I was thinking of Ingrid Bassett is doing some work with her colleagues at OAR in South Africa around placing nurses in hair salons and allowing women to access PrEP and contraception in the hair salon setting, which is traditionally associated with feeling beautiful and empowered, and again, enhances this wellness idea. And then the last thing I'll comment on is this idea of choice. So the Search Dynamic Choice Study, I think, was presented, or some of the data were presented at CROI last month. And to no one's surprise, when we give people choices and options, we see really good outcomes. And I was reminded of how when I gave birth to my son, after my 6-week postpartum visit, I was sent home with this beautiful piece of paper that outlined like 12 to 15 different contraceptive options, and it was pretty and nice to look at, and it very clearly spelled out the pros and cons and how each one was used and side effects in this really digestible way. And I think we need to kind of start doing that and supporting choice wherever possible. Thank you so much.
Thank you, Christina. We're a little tight on time here. We've got one online question. Perhaps, Serena, you could answer. Is condom negotiation being taught? Sorry? Is condom negotiation being taught?
Is it on? Sorry. It's on. Yes, it is. Our nurses are trained to do complete counseling with all our participants. And for example, in the study that I was talking about, we do counseling we train them on how to do the test. We get them to do a practice test in front of us so we know that they know what they're doing. And then we also do role plays in terms of disclosure to partners so that they're comfortable to do so. And if they're not comfortable to do so, then we generally won't consider them for the project.
Right, thank you very much. We will be moving to the third topic and third duo presentation today with comments that will focus on PrEP in the United States. The first presentation on PrEP equity for Black women will be presented by Letitia Elopre. Dr. Elopre is an associate professor of infectious disease at University of Alabama, Birmingham. She is also an associate scientist at UAB Center for AIDS Research and an assistant dean of diversity and inclusion for graduate medical education. And to her presentation, we are going to hear comments from Abby Charles, who is a director of the Institute for Public Health Innovations here in Washington, D.C. and Maryland and Virginia. I have known Abby for years as avid advocate and public health practitioner. She also plays an important role, and in the past was participant and program coordinator of Women's Collective, but today supports our DC CFAR by being a community partnership council and by being a co-chair of Ending the HIV Epidemic Scientific Group. And finally, many of you are very well aware of the WELL project, which catalyzed the change of the guidelines in the United States, and Abby serves as a secretary of the board of the WELL project. With that, I pass the word to you, Letitia, to start the presentation. Thank you.
All right. Thank you so much for having me. I really just want to thank the conference organizers for having I think, a wonderful panel that's highlighting the voices of women, and especially in this HIV prevention space. My talk today is really focused on how and when we can achieve PrEP equity for Black women, especially in the South. I'm going to talk a little bit about the context of what it means to have PrEP equity in the South, talk about some barriers that have been identified, and then hopefully some ways forward. These are my disclosures. So really, I think it's important to have context, and in order to have context, there was this really big initiative that was pushed by the federal government to end the HIV epidemic. I think it's great to have big goals, and I am hopeful that we'll be able to achieve those goals, but the only way to really achieve the ability to end the HIV epidemic in America is to understand why we are having an epidemic in America and the communities that are currently being most heavily impacted. What I really focused on today is one of the biggest goals, I believe, and hopefully one day will be achievable, which is to increase PrEP uptake among vulnerable communities by 50%. So why is this so difficult? The main reason is because we have huge inequities in who is accessing PrEP right now. If you look at right now who's being impacted, who's being diagnosed, we know that Black and brown communities are more likely to be diagnosed. And if you're looking specifically at women, you know that Black women are 17 more times more likely to be diagnosed compared to their white counterparts. When they are diagnosed, they're more likely to have bad outcomes. So the ending the HIV epidemic really is focused on how do we shift resources in an equitable fashion so that the communities that are really facing the burden of new HIV diagnoses are the ones that are getting the most resources. And so in my context, that would be Black women in the South, specifically in rural areas. That is not currently occurring when you're talking about PrEP. So we know that 1.2 million people have an indication for PrEP in the United States. And this is the most recent data. So if you're looking at who has an indication for PrEP and comparing that to who's actually being prescribed, we've made huge gains in some populations. So if you look at white Americans, we've actually gone above our 50% coverage goals. But if you were to look at Black Americans, we are wholly underrepresented in looking at who's being prescribed. And women only make up 14% of prescriptions right now. These disparities are accentuated in the southern US. And right now what we're seeing is with highly effective prevention tools like PrEP, you're actually seeing a widening in disparities, which is something that we try to avoid when we have introductions of new medical modalities. So what are the barriers that we're currently facing? This has actually been studied, not as much as I would like, but there's been a lot of studies looking at what are the barriers to PrEP in the South, and a lot of it focuses on individual level barriers, things like low perceived risk, competing priorities, preferences, and not having enough preference that is being augmented in what's being pushed out. But what I want to point out is that there's not a lot that's focused on system level barriers, especially in a state like my own that has not expanded Medicaid. Insurance is one of the biggest barriers to being able to access PrEP, and we actually don't have that much choice when it comes to options. The ring is not something that's available in the United States, and if you're talking about long-acting options, that's if you can afford them. Also, there's not a lot of access. So this is a map that's showing you where we actually had outbreaks of recent HIV cases in our state. And then if you look at the map of where you actually had PrEP clinics, there were none. So for the people who were within those sexual networks who you would like to refer to PrEP, there were no options available for them. So there's been tons that has looked at how can we investigate this? And I love the social ecological framework. It's been adapted for HIV, and there is a wonderful way that it's been adapted for women living with HIV. But what I hold is that there are some themes that are cross-cutting that we under-investigate that affect people at every level, especially Black women in the South. Things like racism, homophobia, heteronormative puritanical ideals, and stigma. And so when we're creating interventions that are multi-level, that are looking at how do we improve individual, interpersonal, community, and societal level factors that impact PrEP uptake, we have to look at all of these things that are cross-cutting. So I've done some work trying to understand the current context in my state. We did focus groups looking at really urban women, but I want to point out the rural epidemic that we looked at as well. So we went to Lowndes County, which was pointed out by UNAIDS for its environmental racism because they lack clean water. We went to Wilcox, which is considered one of the poorest counties in America. We went to Dallas, which was called the land that God forgot. And we also went to Macon. This is where really I think a lot of civil rights was fought in the South. And we asked women, what are the barriers to you being able to access PrEP? What is causing issues in regards to overall sexual health? And what I wanted to point out really is that when you're looking at the comparison between rural women and urban women, what we found is that the rural women were a lot more in need when it came to insurance. They had much more Medicaid, and for my state, you have to make $4,500 a year to qualify for Medicaid. So highly impoverished. And really, they said, it's stigma. So they said that stigma is one of the biggest barriers, and even if you were to decentralize healthcare options, stigma would still be a barrier because they would still have to run the risk of being identified if they were to access services. They said, what is my locus of control? The ability to actually be able to negotiate with your partner to be able to use condoms is something that most women are not able to do. And one woman eloquently said, every time I have sex, even with my husband, I have to negotiate condom use. So if I can't even negotiate condom use successfully, how do you expect me to use PrEP? And they talked about HIV stigma decreasing PrEP uptake. And there's actually a lot of homophobia that came out in this theme specifically, and the need to address that and have holistic education in healthcare systems, but really in schools, to increase PrEP uptake. We then flipped it and we said, okay, if you could have any type of PrEP you wanted, where would you have it? And we did surveys with over 800 women across our state. We went to those same rural counties to urban counties, and we found, number one, that about a third of women were only willing to use PrEP. But the other thing we found is that women wanted PrEP when they were accessing healthcare services. So they wanted PrEP from a doctor's office, they wanted it from their OB-GYN, which I thought was amazing. And when I saw this, I said, did I really need a survey? I don't think I did. And then they said, we want long-acting and oral. And so what were the ways forward? For us, we made PrEP for her. So we tried to really empower women to be able to access PrEP from their gynecologist. This has been a labor of love. I have a gynecologist that I'm working with named Audra Williams, who's helped me in regards to how to make this as holistic as possible, where we're changing the clinic setting in which women are accessing services. There are a ton of implementation strategies that have gone into this work, and I've been super proud. I'm showing you just preliminary data I have on about 100 women who've already accessed services in 2 months of a 6-month pilot. About 70% are Black, the majority are currently receiving Medicaid, and 90% of these women have actually received a sexual history, when most women said that they were not receiving sexual histories when they went to see their gynecologist. We also had 19 women get PrEP, when before the intervention, no women were getting PrEP in this space. The other thing that we've done is we try to leverage what is already working in our state. And I'm from Alabama. I love my state, but there's not a lot that's working. One thing that is that we actually are able to provide self-collection STI kits free of charge, but nobody was using them. And this is from our state health department. So I said, okay, I'm gonna work with our state health department. I'm gonna have them be co-investigators on this grant, and we're gonna try to get this into the hands of women across our state. And so right now, women have the ability to get self-collection STI testing. They're able to do it in a meaningful way, and we're really working to do this into the areas where women need it the most by leveraging data. So who are the most vulnerable women living in the most impoverished parts of our states who need to have access to STI testing and HIV testing? And as a part of that, we're trying to look at that socio-ecological framework to say, what actually is driving STI and HIV diagnoses? Because I don't think we actually really know. In regards to ways forward, I think a lot actually still obviously needs to be done. So we need providers that feel comfortable taking a sexual history. We know, I'm an infectious diseases provider, most people do not want to come to me to receive PrEP care. When you actually look in the literature for primary care providers, it's the ones who are comfortable taking a sexual history that are more likely to prescribe. We need approaches that are patient-centered, that are human-centered. So that means using implementation science, doing community-engaged research, and doing things like discrete choice experiments where you're asking people, what do you want in regards to PrEP choice? That we're doing things like actually making places outside of the healthcare system holistic and sexually healthy. And so there's wonderful interventions that are being done, like updos, where you're able to learn about sexual health, where you are getting your hair done, and partnering with the Well Project, who's doing wonderful things where they're elevating women's voices. I think storytelling, a powerful mechanism. And last, I do think that we still need to decentralize healthcare services. I think wherever someone touches a healthcare service, they need to be able to access PrEP, and they need to be able to do it in a culturally appropriate manner. And the last thing is a dream, And this is a dream for my state specifically, but wouldn't it be wonderful if, as a child, when you went to your school, you could learn about sexual health, you could access HIV and STI testing, and you could get referred to PrEP? I think that as we're in the state we're in right now, that is not something that's possible. And the last thing I'm going to say is choice is important, but it's only important if you can actually access it. So with long-acting injectables, we did a great job in having something that's superior to oral PrEP, but very few people can actually get it, especially within states like my own. So I'm going to close just showing you what that dream deferred really referred to, and this is a Langston Hughes poem. So we're at a pivotal point in our country right now where there are tons of restrictive legislations being passed. Reproductive rights are under attack. Racism is running rampant in regards to policies that are being pushed forward, and sexual education in school systems are going to be no more. I think that this is actually a time for us as investigators and scholars to take up the mantle and say, how is this impacting sexual health, and how can we really pivot our interventions to make sure that we're tracking what that's doing to health, but we're also making sure that it's influencing how we are really, I think, improving the lives of the women, the men, and all gendered populations that are going to be impacted in a negative way because of it. So that's my talk. Thank you so much.
Fantastic, Letitia. Thank you. Abby, please.
Gosh, how do you respond to that in 5 minutes? I don't know. There's so many salient points in Dr. Elopre's presentation that resonate with me as a single Black woman who is still sexually active. But I have 6 key takeaways, and one of them is that we can't have a discussion about PrEP and Black women without a discussion about racism, homophobia, and the oppressive attack on women's reproductive health and gender-affirming care that we're seeing across this country. When we talk about low awareness of PrEP, lack of information, those are all directly connected to the suppression of comprehensive sexual health education that we're seeing, especially in the South. The second piece that I really took away was that prevention strategies for HIV require integration in primary care, GYN services, and across our communities, in groceries, in libraries. Access and awareness continues to be a huge issue when it comes to PrEP. You know, I had a conversation with some of my friends, and none of them have had a conversation with a provider about PrEP. Many of these women are in their 20s to 40s in a city in Washington, D.C., which we are south of the Mason-Dixon line, and that does have a very high prevalence of HIV. Me, I'm a sexually active single woman. I've never been offered PrEP, and for a long time I wasn't offered an HIV test either, right? I take immunosuppressants, and risk looks different for different women. So that piece about wellness that you mentioned is so critical. How can we encourage conversations about wellness? But also, I see my primary care provider once a year. How do we build relationships of trust with a primary care provider, no matter how comfortable they are with asking questions about sexual health? If I see you once a year, many times people aren't answering honestly about multiple partners, right? They aren't answering honestly about whether they're using condoms. So we have to do a different level of analysis around what does risk or wellness look like. The third piece that I took away was that we must invest in opportunities to support increased financing for community health workers and peer-based workers, right? By increasing awareness for the need for community health workers, and there are acts right now that are before Congress to increase funding and financing through Medicaid for community health workers. And the HIV community, HIV researchers, medical providers, and affected communities and stakeholders must have their voice involved in that, because we can't depend on grant funding for peer community health workers. We need increased access to trusted messengers in our communities, and that can only happen through increased financing. The fourth piece is that violence against women continues to be a concern affecting condom use and PrEP use, and we must address these social norms in order to address PrEP access, right? Condom negotiation, self-esteem, and the value of relationships and childbearing continues to be social norms that we have to address, right? They're all interconnected, and that love piece that ties to whether I'm going to negotiate a condom or pull out a PrEP medication is critical for us to consider. We must understand the barriers of PrEP uptake, right? Regardless of education level, so many of my peers say, even if I could, or if a doctor talked to me about it, I probably wouldn't take PrEP. So the question of why, how much more research can we do? And we need to do more research to understand those barriers that Dr. Ilopre mentioned. The fifth piece is that when equity is not intentionally addressed, inequity is unintentionally replicated. So in our research, in our programs, in our policies, we must ensure that Black women are a focus and are a dedicated part of the population that we're conducting research on. Otherwise, we will inadvertently expand and unintentionally replicate inequities if we don't intentionally address equity. So those are the key pieces that I took away. We must foster additional social support, and that for me is where community health workers, which is my primary focus, come in. So thank you so much all, and we'll move to questions.
Wow, what a powerful closing session of this session. We will just take 2 questions and move on the closure. Anyone who wants to talk more, I will be closing and telling you where to find us. So let's go ahead and grab one there and one here, and we'll stop. Apologies to all that I can't take. Please, number 2.
Good afternoon, everyone. Good afternoon.
Good afternoon. Good afternoon.
So I'm Kangwa Kasonde from Zambia on the USAID Checkup 2 project. So USAID, we're implementing the Checkup 2 activity under John Snow Health. So we reach out to key population as well as adolescent girls and young women on the DREAMS initiative under our priority population unit. So my question or comment goes to Krishna. I didn't want to butcher your name. I didn't want to go all the way. Krishna, I followed you attentively, and amongst the barriers that you highlighted, barriers to PrEP access by adolescent girls and young women, under the community barriers, you talked about the clinic setup and the stigma surrounding AGYW accessing PrEP in the clinic setup. So having implemented the DREAMS initiative for a very long time now in Zambia, so one of the lessons that we've drawn are that AGYW are still very skeptical to go to a clinic setup because they're going to find nurses that are probably related to them. They're going to find nurses that are their mother's friends in the community. So you talked about community health workers doing condom promotion to AGYW. There is a barrier already because they are not relating with this nurse who's much, much older with them. Okay, have you ever tried the approach of, I totally understand that program is being implemented in the health setup, in a clinic, okay? So in the DREAM spaces, these are spaces that are youth-friendly, where they find peer mentors that whatever they talk about is really relatable, because these are people that are probably still going through what they're going through. So have you ever tried to probably use peer community health promoters so that at least we can cut down on certain barriers? Barriers will always be there, but there are certain things that we can employ and replicate. Yeah, thank you.
So the work that I do, we're not in the public health clinics directly. We work in research trial settings, but what we try and do within our settings is to employ staff who are younger and can have a better rapport with younger participants, especially with regards to the HIV testing and counseling and those particular things that we wish that, so we can develop better rapport and get more information from the participants and help them hopefully adhere better.
Thank you.
But I understand what you're saying, and that's something I think we're also aiming for in the public sector as part of Batsarachai.
Thank you. The microphone too.
Thank you very much. Really great session. I mean, I think that it's not unfair to say that HIV prevention is failing women globally. And although adolescent girls and young women bear the brunt of infections, and rightly interventions should be directed towards them, they don't acquire HIV in isolation. And I think it's really important to understand that the men in their lives have a big influence on their vulnerability to HIV, and that when we're thinking about interventions for young women, we really should be engaging men from when they are really young, before they've started to formulate their ideas about what their relationships with women should be with regard to sexuality. And I wondered if any of you have any experience of engaging young men and men in general in these interventions. Thank you.
Anyone?
I've done some work where I've tried to do social capital interventions that focus on improving conversations around sexual health, stigma, and access of HIV prevention among Black gay men and Black women that are present in their lives, trying to capitalize on the idea that it is a community. We don't live separately, and the aspect of us being able to end the epidemic is really going to require us, I think, to stop thinking in these siloed aspects and to really try to think about how can we make communities that are being impacted by the epidemic healthy. So I completely agree with you. I do think that we need to be able to have these conversations and think about these interventions in a more holistic standpoint by still honoring the separate identities and roles and barriers that are present among all of those that are being impacted, but also trying to understand how to build social capital going in one direction.
And I'd say similarly, not here in the US, but in the Caribbean, I did a project with PSI Caribbean where we built a gender-based violence curriculum that focused and integrated HIV prevention that was primarily targeted to young men and girls, where the conversations were around just what do healthy relationships look like? Because I think so much of this narrative around HIV prevention comes from changing our systems and changing those social norms. And a lot of that has to be addressed through policy. A lot of that as well comes with how do we change our culture and what sort of narratives and discussions are we having across genders.
Thank you. So much more hands, but we will round up the session, and then there will be plenty of opportunity to interact with all the panelists, and I will outline those in a second. I'd like to start the closure by thanking NIH for sponsoring this session and for making women in the center of your scientific agenda. Many of the topics we discussed today are perfectly aligned with the signature program that Leslie, you and many others lead at NIH, and that's what we wanted from that session today. If you noticed, our presenters were all other early stage investigators or emerging leaders. Very few very seasoned leaders. Just to frame this conversation, we want to showcase to you it's possible to start asking these questions. As you heard Julie saying, I started asking in the clinic, am I talking correctly about weight with patients? And that leads to research proposal. You've seen other topics being raised. Why the girls not taking PrEP? Where are the barriers leading to research proposals? You heard a conversation about rural and why PrEP is there and not taking and going out of urban settings in south of US and asking this research question, and this becomes a proposal. This meeting serves as a really good base for networking. It is at this meeting that I have heard first time Angelina presenting her mother mentor programs in the UK, and now I'm serving as a mentor on the DC CFAR project, which is a combined, and I'm thankful for NIH for this new mechanism. It's academic community partnership, 2 principal investigators in absolutely equitable roles, talking about equity, leading this research proposal here in DC, and we're trying to create a mother mentor program in my clinic. Very excited about launching this program now with junior investigator in my group and a community partner. This happened at this meeting, so we encourage you all to create relationship, to network. There will be opportunity during the lunch for you. We have made that kind of NIH session table. So we will be there. You can join, come, no matter what level of your training is, even at the student level. Please come over. You have ideas, you have questions, you want to explore what funding opportunities are there, what mentoring opportunities are there, with whom should I work, we are there. And there is also NIH stand available for you to learn more about research opportunities as well. And that's what we wanted from this session. Anyone who hasn't had a chance to ask the question, my apologies, but please do approach us. We are a very informal group. And as I close this session, I have a couple of announcements to make. First of all, I'd like to thank all my panelists. I know they got very annoyed by my emails. But It's been a privilege working with you, and I have gotten to know you closer together with Kate throughout the preparation process, and it's just a really incredibly fun group of women. Thank you for being who you are. And then moving on to the logistics. So first of all, please do complete online survey. It's very important for our session survey. We want to know, did we fit the right format? Do you want something else? After we close that session formally, please follow Christina for the group picture. Those who do not stand in the picture cannot eat lunch. It's a very simple equation. So you are not under the camera. Lunch will be floating away from you. So please do that. It's a fun photo to have. I know in the media area we all like clothes and selfies, but it's always so empowering to see a group of people standing together and coming for one cause together and smiling and holding each other's shoulders. So please do take picture, and please do not forget to be back on time. You were amazing this time. We started the session 5 minutes early, so please be on time. At 1:30 we will start a session called HIV and co-infections. Thank you all for the fantastic morning.